Greetings and thank you everyone for joining us today for this SAFOMS webinar series. I am Ms. Saxena, along with my colleague Dr. Deepika Chabra from Jagsonpal Pharma Ltd, are pleased to extend a warm welcome to all of you for today's webinar series, SAFOMS webinar series, Midlife Quality of Issues on Menopause Rating Scales, organized by SAFOMS with technical partner SMLM.in and Jagsonpal Pharma Ltd, makers of LycoRed, Verena, and Devato. We extend hearty welcome to all the attendees and prominent experts. We are kindly ask the attendees to post your questions, suggestions, clarifications by text in Q&A box. We are already shared the Facebook link on this chat box for you to share on your WhatsApp and spread this message about this webinar. Now I request Dr. Maninder Ahuja, Madam, Vice President, SAFOMS India, and convener of this webinar series to kindly initiate this webinar.
Privilege for me to do these series because they are just a passion for me. This is the one area where has been neglected, and it's not only the quality of life issues only. It's the preventable deaths also which are there, which we have to prevent. So premature deaths are occurring because of the problems which can be very easily recognized and assessed in the perimenopausal period, and then they can be taken off. So that's why we have taken up, and so far even the gynecologists and private practitioners, they are still not aware of what the menopause stands for. It does not stand for just hormone therapy. It does not just stand for hot flashes. There are many more problems of the menopause which are now emerging more clearly when we have started doing more research and work in this area. And because of the sheer number of the women, which they are in millions, and then they have to spend their 1/3 of their life which can be very, very productive and becomes a burden. That's a sad part. So with these words, I'll be just giving a small review what we had done in the last. Dr. Batul Mazhar said very nice thing. Actually the fact that the very few patients they come us to in the menopausal relative for the menopause symptoms, they will come to us with the AUB, with the prolapse, but never for these symptoms. That is why more reason that we should be asking them. And that is what Dr. Hemanta Pereira said, that we are not asking them. We should be pointedly asking these questions about the menopause, which are there. 11 symptoms, menopause rating scales, even that is a tool which even the patients can assess themselves. Then Dr. Meeta Singh said, yes, these symptoms have to be quantified for assessing the patient's problem. Then later on, when they come for review, and later on, if we are having some studies, we have to correlate them, those studies, and we cannot correlate these studies if we are not able to see quantify the symptoms. So that is why these symptoms are very, very much required to be quantified in a menopause rating scale. At the start, I'm very thankful to Dr. Rohana Haththotuwa. It was very kind of him to allow all these series and convened by me, basically because I have an idea that we have to spread the basic knowledge about the menopause before going further, because all the symptoms, they are not only important for quality of life, but the quantity of life also. And Dr. Rohana Haththotuwa is the founder chairman of Nine Wells Care Mother and Baby Hospital, Secretary General of AOFOGS, and President South Asian Federation of Obstetrics Gynecology, SAFOG, President South Asian Federation Menopause Societies, that is SAFOMS, President World Justice Organization, past chair Menstrual Disorders Committee, FIGO, past president Sri Lanka College of Obstetrics and Gynae, and past president of Sri Lanka Menopause Society. I think he's so busy, and I'm sometimes finding that his one leg is in India, one is in the Nepal, and sometimes he'll be going back to Sri Lanka also and doing something. But still, despite being so busy, he's able to manage and coordinate with me in all the process. So Dr. Rohana, today we have our faculties from all the countries, 5 countries, and the webinar basically is being arranged by Nepal Menopause Society, and speaker Shreyashi is the main from them. Then we have a good panel discussion where we have 3 specialists, Dr. Gautam, Dr. Arif, and Dr. Neha, and Dr. the Santi from Sri Lanka. And then we have gynecologist from India, from Sri Lanka, and Nepal also, Pakistan, Dr. Arif, Dr. Jyoti Jaiswal, and Dr. Sina from Bangladesh. She has not still joined, I think. So welcome to all here, and especially welcome to our very dear Dr. Jaideep Malhotra, and who was our immediate past president, and she has been able to join now. And then Dr. Rubina Sohail also. I think we'll request Dr. Rohana Haththotuwa to give a few words.
Thank you, Maninder, for that very, very kind and generous introduction. And so actually, we in the SAFOMS are very thankful to Maninder for organizing this series of webinars on quality of life, actually, which, as he was mentioning, which is a very educative program, and she is touching on symptoms of menopause, taking one by one. And the last one we had on hot flushes, where it was so many aspects were discussed and so many issues were raised, and we were able to come into certain decisions also. So it was a very, very educative program, and it is a very so I think these programs will be very helpful, and at the end of the series, the participants will gain very much, and so that they will be able to gain much knowledge on these common problems, but sometimes our knowledge is not that much. So, so today, actually, we are going to discuss on sleep disorders. This is also an aspect of menopause which is not much talked about, but it is a problem which affects most of our patients, and it is troubling them also. So it is very good that we are able to discuss this topic today in detail, and for that we have really 2 great experts. That is Professor Jaideep Malhotra. I don't think anyone wants, because everyone knows very well, because he has been, he's a real educator and has been involved in so many, almost all the programs, and very knowledgeable in this subject. And she is the immediate past president of SAFOMS. So I'm very, very happy that she joined today. And also Professor Rubina Sohail. And she is also involved with so many federations, organizations, and is busy with teaching undergraduate, postgraduate. But in spite of all these things, we are very happy that she has also joined today, because we can learn very much from her. And everyone really likes to listen to her lectures, which have been very, very helpful. So I'm thankful to both of them for joining today. And also, I wish to wish everyone, in the South Asian region, there are so many countries which celebrate the New Year, mainly in Sri Lanka, I think Nepal, and sometimes in India also. So I wish all of you a very happy and a joyful New Year. And thank you, in spite of this New Year celebrations, for joining in this webinar. And I can see Maninder getting experts from all our member countries. to join in this panel discussion today. So that is also a great achievement. And so we are very happy to see, I think, Professor Shamoda, the the president of the Nepal Menopause Society. I think this is the first time I am, of course, coming into contact with the president from the newly elected president of the Nepal Society of Menopause. So I won't take any more time, but because there is much more in the program. So wishing the program all the success, I hand you back to the moderators to continue with the program. Thank you very much.
Thank you, Dr. Rohana, for those kind words and for boosting our morale also. Despite your busy schedule, you always make it possible that you have to be here. So this time we will be distributing at least digital certificates to all the faculty, so that even we are not able to meet physically, they can keep the memoirs and have it down. I have shared my screen already. My screen is shared.
Yes, ma'am. Put it on full screen.
Yeah, I didn't pull it on purpose only. No. Yes. Yes. So I have already discussed with you these things. This is our flyer of this time, hot flushes, and that was the previous one. We will be doing a recapitulating every time, because a young speaker will talk about the subject, and then the clinical will be just clinical cases will be taken in the panel. That's all. So we have already discussed these points in the last, and just wanted to show you this. The icons of our Indian cinema who are 65, 64, 71 years, Emma, 75 years, Mumtaz, 75, Babita, 75, Sharmila Tagore, Saira Bano, 78 years, Asha, 80 years, Helen, 84 years, and Wahida Rahman, 85 years. Are they not the Vajanti Mala, again at 89 years? So are not they icons of midlife and beyond women? So that is what we have to teach our women also. Our aim is to add colors and health to midlife of women, and not only just years to their life. So this can be done through public and practitioner efforts. All we have to go together. Thank you very much. This was the all for today, and we'll be starting with the proceedings now. First, show the CV of Dr. Jaideep Malhotra, please. They are the experts in our main session, which will be taken by a young gynecologist from Nepal, Dr. Shreyashi, and where she will be presenting all the evidence.
So, ma'am, would you want to
Haththotuwa, this is your certificate, which I think Dr. Jaideep Malhotra can present to Dr. Rohana Haththotuwa. SAFOMS Webinar Series, Midlife Quality of Issues on Menopause Rating Scale. Certificate of Acknowledgement and Appreciation awarded to Dr. Rohana Haththotuwa, Founder, Chairman, Nine Wells Care Mother and Baby Hospital, for participation as faculty in webinar and as president of the association Sleep Disorders in Midlife Quality of Life, a multidisciplinary team on Thursday, 13th April 2023. Thank you, Dr.
Thank you, thank you, thank you, Maninder.
Get them downloaded and framed.
Right. Thank you.
Dr. Jaideep Malhotra is an icon which has been recognized by the government of India, by the UP government, by our all associations being president of. So we can't even count how many associations they have been president. I think nothing is left except some new coming, bubbling up will be there. But then she has gone detailed into not building up her own hospital, which is a state-of-the-art hospital, but beyond that went into making the apps, which will be very, very useful for the antenatal care of the women. Beyond that, so many publications, and she has been the so many journals editor and everything that all of you know. To Jaideep Malhotra, to you again to say a few words. I think you can later on discuss, and before starting also you can give your blessing, and later on you can give your comments on the talk given by our younger Dr. Shreyashi. And in the same vein, I think I'll introduce Dr. Rubina also, who is again very, very close to us. Actually, we have been all working together when we started talking about South Asian Federation Menopause Societies and Menopause Societies as such. So I think Dr. Rubina's CV, please. Yes, Rubina is consultant OBGYN, Hamid Latif Hospital, Lahore, and champion of sexual and reproductive health and rights. And I tell you, she is so active in each and everything. And the actually all the teams I find, Sri Lanka, Bangladesh, Pakistan, Nepal, they are very active in taking up the projects of Indian Menopause Society and doing them. Very proud of them. And it's really privilege for me to be working along with them. So she was past president of SAFOMS, widely published, including IJOG and Lancet, author of books and chapters, upcoming book, Handbook for Midwives, and awarded Young Gynecological Award by A.O. Fogg in 1995. So over to you, two ladies, our icons and our pillars of strength of SAFOMS.
Thank you.
Thank you. Thank you so much. Thank you, Maninder and Rohana. This has been a great, great start with so much academics and wonderful academics which are going on in the SAFOMS platform. And ladies and gentlemen, a very, very good evening to each and every one of you from the beautiful city of Taj Mahal, where I come from. And it's indeed a pleasure for me, you know, to be there as a chair or an expert for this beautiful session on sleep disorders, because left, right, and center, we are all in that age group. I'm sorry to say, like, at least all of us are. And sleep is, and we are also at the receiving end of our patients, where sleep is one of the major problems, and it's such a complex issue, and it has so many attributes to the pathogenesis of sleep that I'm really looking forward to our young presenter Shreyashi from Nepal on throwing some light on the topic, and I'm sure this is going to be a very, very enriching session. And to you, my dear friend Rubina, it's nice to meet you here on this, you know, platform. As Maninder was saying, that we have all grown together on the various organizations, especially in the South Asian Federation, and it's really been a beautiful journey together. So I feel very nostalgic when I see all of these faces, you know, together on one laptop. So looking forward, Shreyashi. And let me just introduce Shreyashi. She is an associate professor of Obs and Gynae at the Kathmandu Medical College. Kathmandu has a lot of nostalgia for me, because we started the first IVF center of Nepal, and I visited Kathmandu every 6 weeks for more than 14 years. So you are coming from my second home, Shreyashi, and I'm really looking forward to listening to you. Now, looking at the CV, it's a very fantastic, you know, CV. She's also a consultant in the Obs and Gynec Frontline Hospital, and the Joint Secretary and Cultural and Scientific Committee Secretary of Menopause Society of Nepal. Has had number of awards, and I see SS Ratnam Award, and I also see an award which has been instituted in the name of my father-in-law, Dr. R.M. Malhotra Award. So it's fantastic to have you on this board, and really looking forward to hearing you.
Thank you, ma'am. Thank you so much. Thank you, Dr. Jyoti Malhotra, ma'am, for such a wonderful introduction. And it's a privilege to be here today in this academic feast on New Year's Eve. And I hope I will be able to justify this topic. So shall I begin, Dr. Ahuja? Yes. Okay, so I'll be talking about sleep disorders in menopause. So as Dr. Ahuja just said, science has added years to our life, and we need to add life to those years. And we as health practitioners have a great role in doing this. And one aspect of adding life to these prolonged years after menopause is to improve the quality of sleep. Quality of sleep is significantly associated with good quality of life. The optimum amount of sleep for a healthy adult is around 7 hours. And decreased sleep has been shown to have detrimental effects on mental health, on cardiovascular health, on cognitive functions, and even risk of osteoporosis. The Women's Health Initiative study has shown that women with less than 5 hours of sleep were shown to have decreased bone density. Further, too much sleep, more than 8 hours, can also be associated with risk of cardiovascular disease, though the cause and effect is unclear. And prolonged sleep may be a marker for underlying disease. The sleep cycle, as we all know, consists of the REM sleep and the non-REM sleep. The REM sleep consists of 20 to 25% of the total sleep, and it has decreased sleep, decreased muscle tone, whereas the non-REM sleep consists of 75 to 85% of the sleep. And this is the good sleep, the deep sleep. And there are 3 stages in this sleep, in the non-REM sleep, and stage 3 is the deepest. This cycle between the REM and the non-REM sleep occurs every 90 to 120 minutes, about 5 cycles per night. Talking about sleep control, there is the two process control of sleep, the 2-modal process. One is the homeostatic regulation and the other is the circadian rhythm. In the homeostatic regulation, the physiological variables are regulated to remain near a defined value. For example, if someone sleeps less one night, then it is compensated by more sleep the next night. And the circadian rhythm is the inbuilt biological clock that we have, which is located in the suprachiasmatic nucleus in the hypothalamus. It undergoes changes at physiological and molecular levels, which responds to external cues like light. So what are the symptoms of sleep disorder in menopause? The first one is difficulty in sleep initiation. There can be hypersomnia. There is frequent awakening. There is early morning awakening. There is less total sleep duration. And the overall quality of sleep may be diminished, which is non-restorative. And there's problem with sense of well-being and overall functioning. And there's narcolepsy, which is excessive fatigue and sleepiness during the day. And a major symptom of sleep disorder in menopause is insomnia. And insomnia is defined as difficulty in falling asleep for more than 3 nights a week. Chronic insomnia is if this problem remains for more than 3 weeks. Short-term insomnia if this problem is for 3 to 21 days. And transient insomnia if it remains for 1 to 3 days. The other less common symptoms are bruxism, which is grinding of teeth, and hypopnea syndrome, which is shallow breathing suddenly at night, which may lead to decrease in saturation, oxygen saturation, sleep paralysis, that is the loss of muscle tone, cataplexy, it may be associated with abnormal movements like sleepwalking, night terrors, parasomnias, which is associated with hallucinations, nocturia, and somnophobia, which is fear of falling asleep itself. So before we go to the prevalence of sleep disorders in menopause, we should mention SWAN study, which is the biggest study designed to examine the health of women during the middle age, that is from 40 to 55 years. And this has been going on since 1996 in different phases. And it is a multi-site study which is going on in USA, and this is an epidemiological longitudinal study. So according to the SWAN study, the prevalence increases with age. So sleep disorders occur in 16 to 42% in premenopausal women, 39 to 47% in perimenopausal women, and from 35 to 60% in postmenopausal women. In another study in which a meta-analysis was done, the odds of experiencing sleep disorders in perimenopause was 1.6, and postmenopause was 1.67, and surgical menopause was 2.17 relative to premenopausal women. So we can see that surgical menopause causes more of sleep problems. we all know gender differences exist in sleep disorders. Usually women have better sleep. In real time also, we can see that women easily fall asleep sometimes in between conversations and when just while watching television, while all the other family members are alert and active, and women tend to fall asleep because they have shorter sleep onset latency, and also maybe because they have lots of work to do during the day, but they have high sleep efficiency, and hormone levels affect sleep in puberty, menstruation, pregnancy, and menopause. And studies show that during menopause, women definitely have more sleep problems. So what are the causes of sleep disorders in menopause? So one is menopause itself, and another is aging. And the most important is the vasomotor symptoms, which is the most common symptom of menopause, and depression and anxiety, and other medical conditions such as cardiovascular disease, endocrine disease, and medications or different psychosocial factors. So talking about vasomotor symptoms, it is reported by 75 to 85% of postmenopausal women. And this is related to poor quality of sleep. Though different studies show controversial results if it is directly related to poor sleep, but since hormone replacement therapy improves sleep quality, so it can be related to vasomotor symptoms. And some argue that there is no close relationship between vasomotor symptoms and sleep disorder, whereas Young et al. From the Wisconsin study population showed that menopause was not a strong predictor of sleep disorders. So all these hormones have a role to play, estrogen, GnRH, FSH, LH, and progesterone. These hormones start increasing and decreasing 7 to 10 years before menopause. So these sleep problems start as early as 7 to 10 years before the exact menopause. So there's decrease in estradiol and inhibin and increase in FSH and LH. The SWAN study showed that increasing follicular stimulating hormone is associated with higher odds of waking up several times during the night, and decreased estradiol has the higher odds of difficulty falling asleep and staying asleep. So progesterone also decreases during menopause. The normal level is 12 to 15 nanogram per ml, whereas in menopause it decreases to as low as 0.5 ng per ml. And progesterone is a very good hormone for sleep. It has both sedative and anxiolytic features. It stimulates the production of non-REM sleep associated with the GABA receptors by stimulating the benzodiazepine receptors. It also acts as a respiratory stimulant, so it has been used for the treatment of obstructive sleep apnea as well. And the most important hormone, estrogen, which goes down during menopause, and estrogen is a happy hormone. It is associated with the metabolism of norepinephrine, serotonin, acetylcholine neurotransmitters, and these affect sleep pattern. It has been proved to decrease sleep latency, the number of awakening after sleep occurs, and cyclic spontaneous arousals, and also increase in total sleep time. So estrogen has another important role, that is it regulates the body temperature, especially at night. When decreased estrogen, this time shift of the coolest temperature changes and the time of temperature drop changes, and this affects sleep. Estrogen also has an antidepressant effect and direct effect on mood by affecting the norepinephrine activity and serotonin response and uptake in the brain. Another important hormone is the melatonin, and this has shown to have a major role in circadian rhythm, especially in sleep onset and in sleep maintenance through the block arousal mechanism. It blocks arousal. But still, the relationship between melatonin and menopause is unclear because the levels seem to fluctuate. It decreases with aging before menopause, but then again, it increases over the years. In some studies, melatonin levels in postmenopausal women with insomnia were lower than those in premenopausal women. And another very important thing which we gynecologists tend to ignore is the mental health issues of the perimenopausal woman. I personally believe in integration of reproductive and mental health, which is very important, and screening for mental health disorders is required at each level during obs-gyne practice. And I think we are lacking in this. And in this sleep disorder also, there is a direct association between mood disorders like anxiety or depression and also are associated with sleep disorders in postmenopausal women and vice versa. One of the main causes of depression is insomnia, and women with hot flushes are more likely to develop depression. Women with depression and hot flushes have a lower quality of sleep than women without depression. And another cause of sleep disturbance is surgical menopause. And the SWAN study showed that 20% of women undergoing hysterectomy with bilateral salpingo-oophorectomy experience sleep maintenance problems. So from the earlier prevalence also, the odds of having sleep disorders was more after surgical menopause, and the SWAN study also shows the same. The problems of sleep during menopause may also occur because of associated sleep disorders like obstructive sleep apnea. The incidence is around 47 to 67%, and restless leg syndrome or periodic leg movement syndrome. And other associated factors may also be related to sleep disorders like musculoskeletal pain, fibromyalgia, GERD, vitamin D deficiency, diabetic neuropathy. And many women also use drugs like beta blockers, bronchodilators, corticosteroids, and different drugs which affect sleep. So these, after the pathophysiology, now a bit on investigation and treatment. So it is very important to know the cause of sleep disorder before we manage it. So the history is very important. And in history, we need to include the type of sleep disturbance, any comorbid conditions, the contributing factors, medications, and what is the impact on quality of life. So to assess all these, there are different subjective and objective measures. There are different subjective questionnaires like the Pittsburgh Sleep Quality Index, Epworth Sleepiness Score, the Stop Bank Questionnaire, and self-reported questionnaires. But there is a discrepancy between the objective and the subjective measures. We also need to go for objective measures like wrist actigraphy, overnight polysomnography, multiple sleep latency tests, continuous EEG monitoring, respiratory monitoring, and leg EMG. So after the assessment, we need to go for the treatment. And the first most common symptom, as we've said, is the vasomotor symptom. So according to the Society of Obs-Gynae of Canada, HRT is recommended. The evidence is strong to high, and it shows that it improves sleep when HRT improves sleep when vasomotor symptoms are present. And it is more effective if started earlier in the menopausal period, and low dose estradiol rather than conjugated estrogen is more suitable. But there's lack of consistency. So currently the guideline of Indian Menopausal Society does not recommend HRT as a line of treatment for sleep disorders among postmenopausal women. There is also a role of melatonin. The newer potent melatonin analogs like Ramiltion and agomelatine have been used. And treatment of mood disorders is important, and it can be done through benzodiazepine hypnotics and newer agents. And these are preferred over barbiturates. Antidepressants and SSRIs can be used. Low dose tricyclic antidepressants may assist in alleviating insomnia. And other drugs, different newer drugs, have also been tried and tested for mood disorders. Non-pharmacological treatment is equally important, and different methods are there like self-hypnosis and cognitive behavioral therapy, which is shown to be superior to sleep medication alone in the long run. And stimulation control and sleep restriction therapies also have shown to help. Routine and behavioral therapy, sleep hygiene is one aspect which has to be considered. Light therapy, especially morning light, which can be combined with exercise and walking, and this will help improve sleep. And getting a good night's sleep is very important in the menopausal transition. And these are the sleep hygiene methods like a regular sleep schedule, avoiding napping in the late afternoon, developing a bedtime routine, avoiding screen time in the bedroom, keeping the bedroom at a comfortable temperature, exercising, not eating large meals close to bedtime, staying away from caffeine late in the day. And alcohol, we need to remind everyone that alcohol does not help in getting sleep, because many women have the habit of taking a little bit of alcohol before going to sleep, and they think it's helpful, but it is not. Other important aspects of lifestyle changes is always important, like relaxation, meditation, healthy eating, dead man's position during sleep, warm milk because it contains D-tryptophan, which decreases onset time of sleep, and always having healthy relationships and being socially active and intellectual stimulation plays a great role in having a good and peaceful sleep. The treatment of associated factors is also important, like treatment of obstructive sleep apnea, restless leg syndrome, fibromyalgia. So this is all I have to say, and I would like to conclude by saying that etiology of sleep disorder in menopause is multifactorial. Sleep disorders are simply a part of aging. HRT improves sleep quality and is considered a primary treatment, but presently lacks concrete evidence for its use. Benzodiazepines remain the mainstay of treatment. Treatment of associated anxiety, depression, or psychosis is most important. And to manage effective sleep disorders in menopausal women, it is helpful to evaluate the cause. So thank you. So with our effort, we can improve sleep in menopausal women. Thank you. These are my references. Thank you so much. Thank you, SAFOMS, once again for letting me speak in this forum. Thank you.
Thank
Dr.
you,
Shreyashi, thank you very much for a very elaborate presentation, and it just highlights the fact that how important sleep disorders are to menopause. And the fact as well that lifestyle is very important in menopausal women, and that when women are, we can stop the screen sharing, please. So I think it is also very importantly highlighted in this presentation that it is not only the medications which will help, but the change in the quality of life and the way we want to live the life in terms of good food, in terms of exercise, and in terms of foods and products which are going to help put the woman to sleep will be helpful. I think it is very also important to say that when we are talking about sleep disorders, we need to realize that more women living beyond 60 are actually physically active in terms of jobs, in terms of workplace environments. So I think that is why it is all the more important that we focus on menopause, we focus on these sleep disorders and make sure that the women are able to go and lead a healthy life when they are going on job at the age of menopause and beyond, because they have a lot of contributions still to give to the society and to the organizations that they're working in. Excellent presentation. Thank you very much. Jaideep, I would request you to make some comments before we go on to the next section.
Thank you, Shreyashi. I think it was a wonderful presentation, and I think we absolutely need to highlight that sleep is just one symptom, because once the circadian rhythm is disturbed, it will lead to many other issues, whether it's metabolic disorders, a cardiovascular disease, depression. There's so many things. There's a lot of association, and especially in this part of the world, we already have a lot of obesity and a lot of metabolic syndrome and a lot of cardiovascular and NCDs. This is really, really important. I really like the line which you said that, okay, women sleep very easily. Women sleep easily because especially the ones who are working very hard, they do sleep easily because they are really tired. That's another very important aspect. So that, what does it tell? That exercise is very important. And I would say, along with the lifestyle, exercise is one important thing which really helps in your mood elevation, plus also a better quality of sleep, which is absolutely essential. I don't believe in medications much, but wherever necessary, we must, take whatever is really required. But I think lifestyle, and another very important aspect which I prescribe to our patients is the yoga nidra. Now, this is something in a yoga which we, normally routinely, especially for even pregnant women who are not able to sleep, we do prescribe. So meditation, exercise, yoga nidra, and the rest of the things are important. Plus, identify the alerting signs which are important, because these are sometimes, the harbingers of what is going to come later. So that's another very important aspect which we should be looking into. So excellent presentation, and it was wonderful hearing you.
I think, Jaideep, it is very important and pertinent to mention over here that we need to also look at the cause of the sleep disorder. So we might be thinking that it is menopause only, but sometimes obesity, increase in the neck, width of the neck, and other things are also contributing to sleep disorders, which may have different solutions. So while we are looking at the quality of life, while we are looking at trying to make the woman become active and be participatory, but we also need to look at the other causes of sleep disorders and also to look at anxiety, because I think you also mentioned that mental health has become a great, it's not only a great topic, but it is a great cause for concern for all of us. So women who are in menopause, their mental health and also their physical health needs to be considered when we are looking at sleep disorders, and adequate interventions need to be put in place to make sure that they are resolved and help as much as we can, because otherwise the non-communicable disease burden is already rising and we will be contributing to that burden if we don't do anything about it in time.
Yeah.
I think, Shreyashi, you have done a wonderful job, especially keeping to the time also. And now what we have to move forward is on your basis also, scientific basis we have to given us, and we will be moving forward for the panel discussion, which will be just clinical case discussions with 3 specialists. So we are honored to have Dr. Jaideep Malhotra, SAFOMS web series, Midlife Quality of Issues on Menopause Rating Scale, Certificate of Acknowledgement and Appreciation awarded to Dr. Jaideep Malhotra, Managing Director, ART Rainbow IVF, Agra, India, for participation as faculty in webinar, Sleep Disorders in Midlife Quality of Life, MDT, on Thursday, 13th April 2023. Jaideep, we are really honored.
Thank you.
And we just don't have word for appreciation of showing your enthusiasm of honor.
Thank you, dear. Thank you. Thanks for having me.
Yeah. You are here. You are our soul. So SAFOMS webinar series, Midlife Quality of Issues on Menopause Rating Scale, Certificate of Acknowledgement and Appreciation awarded to Professor Dr. Rubina Sohail, Consultant Obstetrics Gynae, Hamid Latif Hospital, Lahore, Pakistan, for participation as faculty in webinar on sleep disorders in midlife quality of life, MDT, on Thursday, 13th April 2023.
Maninder, dear, thank you very much for making me a part of this. It's always a
I am
privilege.
really honored to have you. You people just don't know how close you are and how much you have been helping us. Together we can do a lots of things, and I think midlife is where we have a long way to go. So the only thing, because we are the initial torch bearers, so we have to continue together for a few years before we can really make a dent.
Excellent. Thank you very much.
Thank you. Thank you for being here. And we'll be inviting you for other future webinars also. There are going to be 9 series till we have actually understood thoroughly the menopause rating scale and how to manage them each.
Thank you.
Because sometimes the symptoms come together, sometimes they are alone. So there will be constellation of symptoms, so constellation of problems, and how we have to do. So every time we have to discuss in some form menopause hormone therapy and alternative therapies also. Next, Dr. Shreyashi, SAFOMS webinar series, Midlife Quality of Issues on Menopause Rating Scale, Certificate of Acknowledgement and Appreciation awarded to Dr. Shreyashi, Aryal, Associate Professor of Obstetrics Gynae, Kathmandu Medical College, Nepal, for participation as faculty in webinar, Sleep Disorders in Midlife Quality of Life, MDT, on Thursday, 10th April 2023. Shreyashi, I am indebted to you for making such wonderful presentation, but also to Dr. Sada also for giving me a speaker so good, and later on she will have to do all the summing up and everything, because actually it's her webinar and not mine webinar. And I'm really, again, I'm repeating, I'm really grateful to have complete cooperation of all the countries and all the speakers in making these webinars successful. Now, should we go with the panel discussion?
For the panel, we have the moderator, Dr. Maninder Ahuja, and her panelists that she's going to introduce now.
We have a team of learned panelists with us, from one from each country, and Dr. Arif Tajammul is from Pakistan and is a professor of obstetrics and gynecology of Allama Iqbal Medical College, Lahore.
Medical College.
Principal and head of academic. Yes.
Past
Sir,
principal.
correction.
Past principal, just a few months
Past
back.
principal. Okay, it's okay for us. You have been at it. So past principal and head of academics, teaching and clinical post assisting candidate of FCPs and MRCOG examination and tutor in postgraduate courses in obstetrics and gynecology in Lahore. At least we have such a learned person with us talking on menopausal problems. So that is very important for us. Again, I just read a few lines more. Please go back. Yeah, he's assisting in development of endoscopic minimal invasive surgery unit and carrying out diagnostic and operative hysteroscopy and laparoscopic surgeries. Inspector of medical colleges by Pakistan Medical and Dental College, published many papers and articles in many journals, and editor of the Survival Guide 2010 book for preparation for the FCP Part 2 examination. Editor of Comprehensive Review FCPs, MRCOG and Obstetrics and Gynecology. Welcome to you, sir, with this webinar, and we are waiting for your great inputs. Next is Dr.
Pleasure
Jyoti
to be
Jaiswal.
here. Thank you.
Yeah, next is Dr. Jyoti Jaiswal. She's from Raipur. She's the professor and HOD of Department of Obstetrics and Gynae, JNM Medical College, Raipur, and she's a very, very active participant of Indian Menopause Society for so many years, and she's vice president of ISAR, Raipur Obstetrics Gynae Society, and secretary general of Raipur ISOPARG also. So you know how much multi-talented she is, and she's person of the chairperson of quiz committee in Indian Menopause Society and chairperson of the medical education committee also there. And now she is the General Secretary of Raipur Obstetrics and Gynecological Society. And in IMS, you are now, you're not returned?
I will be the incoming treasurer, madam.
Yeah, she is the incoming treasurer. So lots of awards and lots of work she has done. Welcome to you, Jyoti Jaiswal.
Namaste, everybody.
Next, we have Dr. Shahi Farzana Tasmin, all Bengalis from Bangladesh. All the doctors are really very beautiful. It's always, they are a sight to look at. Designation is former professor obstetrics and gynae, Rangapur Medical College, Rangapur, Bangladesh, vice president OIG SP, that is outside Dhaka, and council member of SAFOMS and organizing secretary of Polycystic Ovarian Club of Bangladesh outside Dhaka, and organizing secretary FSSB Fertility and Sterility Society of Bangladesh. Welcome to you, Dr. Shahi Farzana, and we're waiting for your inputs. And then we have our specialist from India, who is the senior consultant head of Department of Neurology, and she's a neurology specialist plus sleep therapist also, and she's DM in Neurology AIMS, and she has been teaching the DNB medicine students here and member of editorial boards of index journals and Annals of Indian Academy of Neurology. So she is going to contribute towards all the related problems to sleep disorders which can occur in the menopause. Next is our young Dr. Yogesh. I don't know how much young he is, but to me he looks very young and very, very forward motion. So that's why I liked him, talking to him. Otorhinologist and head and neck surgeon, fellowship in snoring and sleep apnea surgery. So that is what we rarely get. So we are lucky to have a fellowship person of snoring and sleep apnea. So many divorces will be saved, I think, by him. And associate professor, Department of ENT, head, neck and surgery. So he is a ENT specialist along with a sleep therapist and editor, and many publication and editor of Nepal Head and Neck Cadaveric Dissection Manual, and several lectures, guest lectures, keynote delivered, and workshops conducted in many publications. Next, we had Dr. LDD Akmi Mana. I thought I'll make her short, Akmi Mana only. Assistant Secretary, Menopause Society of Sri Lanka, member Board of Study in Psychiatry, And it really, we are lucky to have her here. And thank you to Sri Lanka, Piyusha, for finding her for me. And she's the council member of the Menopause Society of Sri Lanka, committee member, Ladies Forum of Obstetrics and Gynecology of Lanka, and treasurer, Sri Lanka College of Psychiatry, committee member, Clinical Society of Colombo South Teaching Hospital, and treasurer of the Sri Lanka College of Psychiatrists. And welcome, Dr. Akimi Mana, because I know your inputs are depression and relationship to sleep disorders is going to be very, very effective. I think now we'll start with our presentation with all these speakers introduced. Sleep disorders and dysfunction midlife dilemmas and discussions. As we have seen already, there are going to be lots of dilemmas and discussions, but already Dr. What was the speaker? Shreyashi. She has made the job easy. We just have to go click quickly with the clinical cases. But I understand, see, look at into Ravi Shankar said that understanding sleep can unlock the many secrets of our consciousness. And that is true when we'll be talking about depressions and what is sleep cycle and all that. So it's not only that our daytime activities affect our sleep, but our sleep also can tell us some things about our personality. So sleep problems are important, not because of the prevalence which is there, especially the prevalence which starts from the perimenopause or menopausal transition period, which is very, very important. And this in the self-reported symptoms, this comes at the top of the symptoms when we are getting the symptom. And all the menopausal classification system, they have that earlier menopause symptoms, sleep disorder, mood changes, they come in the menopause transition. And after menopause rating scale is mentioning sleep disorder, difficulty in falling asleep, difficulty in going through the sleep and waking up early. So we have to quantify, and sometimes they can be seen alone, or sometimes they can come with the conglomeration of other symptoms combined, and we have to then quantify on the menopause rating scale whether we should be treating or give them the alternative therapies on sleep. So we have already talked about panelist hour and introduced them. So sleep disorders can be because of the hormonal influences. Already Shahi has said circadian rhythm, lifestyle changes, depression, insomnia, restless leg syndromes, or sleep apnea, then objective diagnosis, polysomnography, actigraphy, or subjective by clinical interviews, or self-reported symptoms by the patients. That is very important. And treatment, basically they have been writing that cognitive behavioral therapy, even on internet, is the #1 therapy should be there. Then for the sleep apnea, positive pressure is there. Then pharmacological treatment, hormone replacement therapy, and other psychotropic drug medications will be taken by our speakers by continuously. So we have already taken the sleep disturbances can be described subjectively by the patient when they are sleeping. So let's look into the first case. Angelina, she's 47 years, she's having history of irregular period for 6 months. So that means she has already passing through that menopause transition, and she has started having this complaint, doctor, not able to sleep. I feel tired. So that is the way the patients can present to you even directly with the problems, because the other problems which they are having may not be that important. So subjectively about other symptoms, you will have to ask again and again them. Otherwise, they may not tell you the other symptoms of menopause. So Dr. Dasanti Akmemina from Sri Lanka, what is sleep cycle and what are basically sleep disorders? So before we start talking about sleep, just in short, tell us what is sleep cycle and what are basically sleep disorders.
Sleep cycle is a fluctuation between the slow wave, non-rapid eye movement sleep and rapid eye movement phases of sleep. So normally it lasts around 70 to 110 minutes. Typically an adult first enters non-REM sleep and passes through 4 stages of sleep according to the past classification. Now it's called N1, N2, and N3 stage, and all last about 70 to 100 minutes in one stage. So in one stage actually starts right after you fall asleep and very short and usually lasts only less than 10 minutes. It's light sleep and can be awakened easily. Then N2 sleep lasts for about 30 to 60 minutes and muscles become more relaxed, maybe begin to have a slow wave delta brain activity during that time. So N3 sleep, sleep at stage 3 and 4 according to older classification, it's a deep sleep and lasts about 20 to 40 minutes. Delta brain activity increases and you may have some body movements as well. Sleep then lightens and the REM period follows. So during REM, a person's brain activity, breathing, high heart rate and the blood pressure increase and the eye move rapidly while closed. The muscles in the arms and legs become temporarily unable to move, like paralyzed, and first REM period typically lasts 10 minutes and each of your later REM stages gets longer and the final REM may last up to about an hour. So heart rate and breathing actually increases and quickens during the REM stage. This cycle repeats at intervals about 90 minutes throughout the night. So cycles are similar, but there is less stage 3 and 4, that is N3, and more REM sleep towards morning. So usually 4 to 6 REM periods occur per night, and occupancy of REM sleep tends to drop towards elderly. So sleep cycle is under the control of neurochemical systems and neuroanatomical centers. So non-REM sleep is associated with serotonergic neuronal activity and originates in Rafiq complex. And REM sleep is associated with noradrenergic neuronal activity and originating in the locus coeruleus. So sleep disorders are caused by the brain's inability to regulate sleep-wake cycle normally. Actually, sleep problems are important for several reasons. As Dr. Shreyashi said, they may represent primary sleep disorders, or they may be symptoms of a psychiatric disorder or occur in a range of medical disorders. They may be causes of psychological symptoms and contribute to onset of psychiatric disorders such as depression, dementia, etc. Or persistent sleep difficulties are associated with adverse physical health outcomes. Basically, actually, sleep disorders can be classified into 7 according to the ICD-11 classification. So insomnia disorders, hypersomnolence disorders, sleep-related breathing disorders, circadian rhythm sleep-wake disorders, sleep-related movement disorders, and parasomnia disorders. I think Dr. Shreyashi has discussed most of them under her speech. So I don't want to go into more detail at the moment. But, okay.
Thank you, Doctor. That was a wonderful explanation. And now we have been able to understand how the sleep cycle occurs. So self-reported symptoms can be there, or objectively measured indicators will be there in some cases. So as we move forward, we'll be seeing how they are. But what we have to understand now is the menopause cause of sleep disorders? Some studies say no, sometimes whatever panelists are going to say, are menopause symptoms responsible, or is the hypoestrogenic state which is irresponsible? How to diagnose, how other health hazards, how they are occurring with the sleep disorders is very important. How to manage, when to treat, refer these patients is very important, and sleep hygiene, which can be the first step taken, is also very, very important. So these symptoms will be self-reported, then we'll see the clinical experience, and evidence-based medicine will be there. Now, Dr. Jyoti, how much sleep do we need, and how sleep affects our daily life?
First of all, thank you, madam,
for small just introduction from you.
Actually, first of all, thank you so much for giving me this opportunity. Second, everybody is remembering nowadays RRR. You know, RRR movie is very famous. So here also I would like to say about the RRR that sleep is going to help us in the repair and then restore and then regenerate not only for the body but also for the mind. So sleep is very, very important for the healthy functioning, as well as the time to give brain repair and re-energize. And when we say that how much sleep do we need, so it depends on the situation or the age of the patients. Like the child and a newborn needs much more sleep than the adult, and an average adult needs about 8 hours of sleep. More than 60 years of patient may need 8 to 9 hours of sleep. They also be needed. But for the younger and the teens, the need requirement is about 9 to 10 hours.
Thank you, Jyoti, for summarizing that so well, because there was a time when I used to sleep just 4 to 5 hours, and I think that caused my CVD problems also. So we all need 7 to 9 hours of sleep daily. Please remember that. How many emergency cases or whatever, you have to complete your sleep. Now let's go to the clinical case. Patient Meenakshi, at 52 years, come to your office, menopause since 2 years. That is how they will be coming. Complaints of hot and cold feeling and gabrat and confirmed of night sweats. She was not very particular talking about the sleep, but when you asked her, she said for the last few months, she's getting up at night. She's an executive and is feeling upset, as during daytime, she's feeling very fatigued and is not able to do her work. Now that is happening very frequently. Her BMI is 24, no history of diabetes or hypertension. She has gained weight about 2 kg during these months also. Now, why do we gain weight when we are not able to sleep? Maybe because we eat more during that times of waking up. So Shahi, Farzana, to you, are menopause hot flashes related to sleep disturbances? Just be quick about that. Are estrogens responsible for sleep disorders? And what type of sleep disturbances are reported in Swan's study, which was already taken up by Shreyashi, but we would like to recapitulate it again and repeat it again for the benefit of our delegates, so that they can understand now better in relation to clinical symptoms.
Thank you very much, madam. First of all, I would like to thank you for giving me the opportunity. We all know that menopausal menopausal sleep disturbances is one of the most bothersome symptoms. And we all know that 40 to 60% of the women reported that she suffers from sleep disturbances according to different studies. And most of the common sleep problems, according to Swan study, is nighttime awakening. And self-reported vasomotor symptoms consistently associated with self-reported poor sleep quality and chronic insomnia. And according to Swan study, 80% of the women suffers from vasomotor symptoms. And some of them, we can see some of the studies that serious, the study like polysomnography, which study the sleep disorders with vasomotor symptoms, they give inconclusive data. Like in the earlier stages, they showed that there is no relationship between the hot flashes and the night sleep. But on the later studies, they showed that there is a relation between hot flashes and night sleeps. Studies have also shown that there is increased incidence of sleep disorder and patient having vasomotor symptoms having chance of more nighttime sleep disorder according to some studies. And overall studies shows that hot flashes consistently associated with sleep disorder, and according to Swan study, nighttime awakening is one of the most important symptoms. And longitudinal study of Swan showed that women who are suffering from moderate to severe vasomotor symptoms are at least 3 times more increased risk of nighttime awakening. But all the women don't complain of hot flashes with having sleep disorder, so that other causes of sleep disorders should be looked for, like mood changes, comorbidities, social factors, and sleep disorders also.
Thank you, Dr. Shahi Farzana. You have very, very nicely elaborated. Yes, the sleep disorders in the SWAN studies, longitudinal, they have difficulty in falling asleep and keeping awake, and early awakenings are there. But you have very important point highlighted that with somnography, earlier hot flushes are sometimes related to those changes in polysomnography, but not the late sleep disturbances. They have not been so far associated with the sleep disturbances. So might be these patients may need two types of treatment then later on, depending upon which sleep problem is responding to which type of medication now. So what are the, Jyoti, what are the mechanism of sleep disturbance and hot flushes, and are sleep changes with hot flushes seen on somnography studies? They have been taken up anyway, but you can take again.
Ma'am, actually, as Dr. Shreyashi very well said that both the estrogen as well as the progesterone, both has the relationship with the sleep, because a good night's sleep, the estrogen is responsible for the relaxation, and progesterone is itself is a sedative. So in the early postmenopausal and perimenopausal time, the impact of disturbances of these two hormones can lead to and may be associated with the sleep disturbances. And basically, the progesterone is responsible for for the initial sleep problems, and for on the when we see that there is a reduction in the prostaglandin synthesis also, and that is also involved in the sleep problems because of this, and potential link between the thermoregulatory, that is the hot flashes which we were talking about, that whether the vasomotor symptoms are related to this or not. So because of hot flashes, there may be night sweats, and night sweats can disturb, and they can disturb the intermittency of the sleep in between at night. So these are the things which are associated with sleep disturbance and menopause.
Yeah, Jyoti very nicely said that they can be related to, as Dr. Shaina also said, the sleep latency, arousals after sleep, but they can act either directly on the centers, or they can act through the other hormones and neurokinins also. And they have antidepressant effect. So when the short is, they are hypoestrogen, then depression is also increased, and because of the thermoregulatory control also they are controlling. Now, Dr. Arif, a role of progesterone and FSH in sleep disorders, has been proven?
Thank you very much. It's an honor and a privilege to be here today at such an exalted forum. Now, the female hormones, we still do not understand them very well as to their effects on the human being. And estrogen and progesterone, the more we dwell into this, we find out that their role into every aspect of a woman's life is very, very paramount. Now, progesterone and estrogen both have different workings, but some of the things they share as well. Progesterone is both sedative as well as an anxiolytic feature, and lack of progesterone does lead to problems. In addition, progesterone also acts as a respiratory stimulant, as we know from pregnancy, that elevated levels of progesterone do raise up the respiratory rate. And similarly, estrogen has also got a role into that. And the association with GABA is very, very important. And the benzodiazepine receptors, once activated, can actually lead to a better sleep if the progesterone levels are good. Now, some studies have worked on FSH, and the increased level of FSH to some extent are related with waking up at night. And along with that, decreased level of estrogen. These are the things that we see in menopause. And we observe that sleeplessness or waking up multiple times during the night is to some extent associated with higher levels of FSH, along with the drop in the estrogen levels.
Yes, Dr. Arif, you have very rightly pointed out that the female steroid hormones are there with women from womb to tomb. So at every stage of life, they are important, but in the menopause transition, they are really causing a havoc because of the sleep disturbances which are there.
That is
Which
correct.
have been proved, yeah. Which
And
have
unfortunately,
yes.
as any human ages, male or female, their ability to withstand these problems also decreases.
Yeah.
So when you need your reparative mechanisms at their maximum, that is when you are a little short on those. So it makes up a soup of problems.
Yes. So it's very important that we start looking at these problems very early. That is very
Absolutely.
So we should try to prevent these problems from occurring, because once they have occurred, with already our withered stores, we cannot recapitulate them, get them, regrow them. So we have to prevent. So prevention is the main. So that's why we should start looking earlier these problems and assessing, asking the patients to assess themselves, and we should be assessing these patients on every visit. So that was the
Absolutely. And I think understanding them from a patient's perspective is very important as well.
Yeah.
Because we busy in our practice at times do not give that much importance to these things. Like we deal with
that is the thing.
like
So that's why
life-threatening issues. And
Yes.
once a patient talks about these things, we at times tend to just write it off as a normal process of aging. And that's just not right, because it affects their quality of life.
Yes, and sleep disturbances can be a very warning sign for future cardiovascular risk factors,
Absolutely.
for the heart factors, for the lungs, for other DVT phenomena also. So we simply cannot ignore sleep problems and refer to them without giving them some sort of treatment which they need in perimenopausal, because once
Absolutely.
they are out of our area, they are going to be under SSRI, SNRIs, or hypnotics, or whatever it is. So we as gynecologists have to understand the sleep and steroid process, how they are acting now. Now the same, this was the cases which were coming with hot flushes. So hot flushes came, and we now we have discussed that the progesterone, estrogen, and FSH, they are all required. So when we have to give them treatment, we would be looking into these cases like that they have to be treated for these symptoms. And along with that, if sleep disturbances get okay, then it's okay. But if they are not getting okay, that means there is another part to that insomnia, then we have to refer them. Now, Narmada, 55 years now, she's coming up, complains of waking up frequency 5 to 6 times in night to pass urine. And then she finds it difficult to go to sleep. But sometimes awakenings are not related to urge to pass urine. So sometimes awakenings can be without urge to pass urine. When asked subjectively, she says she has dryness of vagina also, and itching and dyspareunia, and so lost interest in sex also. Urine culture is sterile. So now this is one of our patients who has come with another problem, but again that problem is causing a sleep disturbances. So can it be associated with that, Dr. Arif?
Well, yes, because the aging affects the genital tract and the urinary tract as well. And it doesn't always have to be infection. Like sensory urgency is a very common problem we see in these patients. So the urge to go and urinate leads to insomnia. And as the patient is awake, the kidneys keep on producing more urine. So it ends up into a cycle with recurring wake-ups and going to the toilet and coming back, and unfortunately makes things worse.
So subjective symptoms also, they have said that yes, the getting up in the night for passing urine is disturbing their night and is the cause of poor sleep also. Now another cases, they come to us. They are coming to us, but somehow or the other, we are just subjectively treating them. As Dr. Batul Mazhar last time said, they come to us with prolapse and abnormal uterine bleeding. So might be they have come to us with some other problem. Maybe we have given them some other problem, and in the meantime, they develop the sleep problems also. So we should be looking up and following up these patients. That is very important. So bilateral salpingo-oophorectomy was done at the age of 39 years because of endometriosis. And she was not given any HRT and no counseling. And she's in a bad shape. She's having sleep disturbances. She is fatigued. She's not able to work. But about her treatment will come later on. Management of all these conditions will be taking later on. Another presentation can be Supriti 45, which is a breast cancer survivor. There can be other cancer survivors also who are on to the other drugs. She's on tamoxifen for long periods. She's having dry vagina, inability to have a proper sleep. These patients have lots of these problems, and extending their life and not giving them in quality of life, I think is not justified at all. So we have to look into both the angles and how to treat these patients, then we will be looking into later on. So midlife problem are a heterogeneous group. Given the wide range of potential sleep problems, it is expected that sleep disturbances during midlife is multifactorial and that several sleep disrupting causes may occur even within an individual woman. So challenge of making attributions of sleep disturbance to specific health conditions is made even more complicated by age-related increase in sleep problems that can be difficult to disentangle. So they are having sleep disorders, can be vasomotor symptoms, hypoestrogenism. There are other symptoms of hypoestrogenism, depression and anxiety. Primary sleep disorders can be there, like obstructive sleep apnea, restless leg syndrome, PLMD, GERD, etc. And then aging and medical illness problems, fibromyalgia, cancer, obesity, thyroid, chronic pain. All these can add to the problems of the women. So we should have an analytical mind. So, Arif, I'm coming to you again now. What are the health-related effects of sleep deprivation?
See, most of the things that now we are finding out through research are what we knew, that if somebody doesn't sleep well, they don't perform well, their judgment is not right. If you're driving in the morning after a restless night, you're not able to actually perform as well as you should. And now coming to the objectivity of things, we know that there is a rise in cortisol levels along with some of the other hormones, which is the waking up phenomena. They start to peak around 3 to 4 a.m. in the morning. The thyroid stimulating hormone also goes up, but when the sleep becomes better, it starts to come down. We always knew that children grow more while they are sleeping, so the growth hormone causes better growth in children as well. And along with that, there are other things like ghrelin and leptins, which increase our craving for carbohydrates. So if somebody does not sleep well, they tend to be overweight because they eat more carbohydrates.
Yeah, so like me, if I get up or if I'm sleeping late, I will just gulp up whatever sweets are there lying down. That means whole box will be gone. So what's the effect of sleep and beauty?
Well, one thing that I do is I keep my fridge empty, you know. So when I get up at night, and if I want to eat something, there's nothing there.
Even I have tried doing it, but then I walk to the other bedroom of my son also and find out if there's something to eat.
Correct.
Anyway,
so
what about the effect on beauty, please?
Well, you know, beauty is a $1 billion question. And well, for males as well, but especially for females, looking beautiful is important. And I think for males, it is important to see beautiful females around us. But instead of spending a lot of money on different therapies and serums and whatnot, I think the contribution by a good night's sleep is substantially more than what some of these products can do, because the collagen gets impaired if the one does not sleep well. You see more lines on your faces, premature aging of skin, the breakdown does not improve, and then again the hormone levels go up and down as well. So a good night's sleep is really important to stay beautiful as well.
And what about memory loss?
Yes, and we all complain in these years that we don't remember things well. But most gynecologists have a lifelong history of sleepless nights. So it does stem from that. And over the years, the habit of sleeping less ends up with short-term and long-term memory losses. And at times, the mind starts to wander away and the concentration becomes difficult as well. So good sleep hygiene can help. One should actually shoot for about 8 hours in the night, 7 hours at least, and try to minimize caffeine intake in the morning, which we are so used to. And then looking at the DNA itself, well, good sleep is also associated with longer life, because as we age, our DNA in the cells tends to shorten. And that is said to be one of the reasons why humans do not live beyond 100 or so what, because that is when our DNA gives up. And if one sleeps well, then the shortening of the TLs is reduced. And so hopefully it might transform into longer life and better health if we keep our sleep practices good.
Yeah, this was reported in our International Menopause Society journal. So that's why I took it from there, that this is very good, that even the telomere
Absolutely.
going so health hazards of sleep disorder, as you have mentioned, are very daytime decrease fatigue, daytime functioning, reduce higher incidence of automobile accident, depression, more psychological medical problems, including those of respiratory, gastrointestinal, and musculoskeletal system. Can divorces be there? Yes. If so that is also sleep hazard. It's a big
And
sleep
even
hazard.
the anxiety, depressions are very high, mood changes are very high if a patient remains sleep deprived. And the cardiovascular disease, hypertension, diabetes, insulin resistance, that are also studies are also showing that these things are on increasing. The chances of obesity is increasing when you do not have a proper sleep and remain sleep deprived. And even the early death, as this study was saying, in menopause life.
Yeah. So our three gynecologists now have come to the conclusion that sleep is of utmost importance, and the perimenopause menopausal transition is affecting our sleep, which we have to look into. That is very important. Now, this is what happens now. Neha Kapoor, role of melatonin in the sleep problems, because we have taken the estrogen, steroids, we have taken role estrogen, progesterone, FSH, everything. And now the role of melatonin.
Good evening, everyone. Ma'am, I would really like to thank you, first of all, for giving me this opportunity. So melatonin is a hormone that is made in the body by the pineal gland, and it basically regulates our night and day cycles, or the sleep-wake cycles. And basically the darkness, it triggers the body to make more melatonin, and that helps the body to go off to sleep. And light basically decreases melatonin production and signals the body to awake. So insomnia is a major complaint amongst the menopausal and the post-menopausal women, because it is probably because of decreased level of estrogen and possibly because of decreased level of melatonin as well. And so it has been seen that in menopause, there is a sharp decrease in both estrogen and melatonin both. So one can give a trial of melatonin to patients who are having a difficulty in sleep onset. The dosages of giving melatonin ranges between starting from 1 mg to 5 mg. And the timing of giving melatonin can be somewhere between 2 to 3 hours, just few hours before going off to sleep at night. So melatonin is a sleep hormone which can go to a lower level in a menopause or the post-menopausal time period.
By which name it is being available in India?
By the name of melatonin, you are having this brand available. Even in Faridabad, if you write melatonin, 3 mg, 5 mg, and 1 mg is the dose strength that you get it in.
So getting it. So we can start prescribing after all, because it doesn't have many side effects. So even as a food supplement, sometimes some foods are rich in melatonin, they also be taken.
Yes.
So it can be taken, advice to the women who are just having mild problems of hot flushes, but severe sleep disturbances are there.
Yes.
Now the other case is Parnita. Now we have seen cases with hot flushes, with sleep problems, with urinary problems, and the role of melatonin and all the steroids. Now, Parnita, 48 years old patient, reported with feeling disturbed, having lost interest in life. On interrogation, reveals irregular periods, occasionally hot flushes, some 3 on score of 3 on menopause rating scale, fatigue, difficulty in going to sleep, and early awakening. So if we calculate score, that will be around, then come to 14, 15. She cannot keep her assignments, has gained about 4 kg of weight, no history of diabetes, hypertension, but children have moved away and husband is doing well in business. She doesn't have anything to do. So Dr. Dasanti, I mean, she's from Sri Lanka, and I'm very lucky to have her here, because when we start talking about depression, we just don't know how to be talking about that. Is patient depressed, and relationship between depression and sleep disorders. So over to you, Dr. Dasanti.
Yeah, thank you very much, Dr. Maninder. Yeah, Maninder again giving me this opportunity to talk in this forum. Actually, it's a very important topic, as all of you have pointed out. So relationship, if you talk about depression with sleep disorders, sleep problems often coexist with symptoms of depression or anxiety. So sleep problems can exacerbate depression or anxiety, and depression or anxiety can lead to sleep problems. So lack of sleep and too much sleep are linked to many chronic health problems such as heart disease and diabetes. So reduction in estrogen and progesterone hormone levels can trigger mood swings that make you less able to cope things you would normally let roll off your back. So some women with the past episode of major depression are at an increased risk during these hormonal changes. So women with low estrogen levels may be more prone in developing anxiety and mood disorders, or experience worsened symptoms when they face stressful or traumatic events. This can happen in midlife, actually, because estrogen has potent serotonin modulating properties from the level of neurotransmitter synthesis via the regulation of tryptophan hydroxylase. So, and degradation of serotonin to the density and binding of serotonin receptors. So estrogen increases serotonin receptor levels via gene expression and is reported to induce the increase of serotonin binding with serotonin receptors. Therefore, in depression, actually, disturbance in sleep architecture is seen. There is a reduction in stage 3 and 4, that is N3 sleep, and reduced REM latency. And REM occurs earlier in night, not in the latter half of the night, it's early in night. And disturbance of sleep continuity is seen with more time awake, increased sleep fragmentation, early morning awakening, and may experience periods of excessive daytime sleepiness. Actually, sleep deprivation, especially REM sleep deprivation, has a beneficial effect on mood in depressed patients because of that reason. And sleep problems can exacerbate depression, leading to a negative cycle between depression and sleep. And they have a bidirectional relationship. And sleep problems commonly associated with depression include insomnia. Actually, 80% of patients in depression experience bouts of insomnia. So hypersomnia also, 15% of people with depression have hypersomnia, and obstructive sleep apnea also. So 20% of people with depression have obstructive sleep apnea. Therefore, sleep issues may influence the function of serotonin, which can contribute to the development of depression, and sleep disruption can affect body stress system, disrupting circadian rhythms and increasing vulnerability for depression. So those are the actually main causes for depression during midlife due to sleep disorders. Yeah, thank you.
Okay, so Dr. Dasanti, what I can assess from this statement is that the estrogens and depressions both are responsible for depression also. They are interrelated, and for the symptoms also. So that means these depression patients, we can give them estrogens to start with, and they can respond to that early estrogen treatment also.
Actually,
so
it's not
hypothesize that the fluctuation and eventual drop in estrogen is responsible for the impaired mood.
Yeah, that's true, but it's still not recommended. They have done studies, then they have found that actually these patients need to be given antidepressants, even though it's related to estrogen deficiency. So that's the problem. We can't use hormone replacement therapy. Yeah.
Hot flushes and mood disturbances, then we can combine them also.
Yeah, if they have hot flushes and other vasomotor symptoms, we can think of hormone replacement therapy, but not for depression itself. For the depression itself, we have to consider antidepressants mainly. So the SSRIs, as Dr. She has said, a lot of antidepressants are used, SSRIs, SNRIs, even electroconvulsive therapy also
that
can
we'll
be
be discussing later on. That we'll discuss later on. So as discussed, there are potentially here.
Can I add one thing here, ma'am?
Yeah.
Ma'am, particularly when the indications of hormone therapy is there, like you said that vasomotor symptoms are there. and
Yeah.
the sleep disturbances are also there, the sleep disruption is there. So in that condition, the early window of opportunity we take, the better the results will be there for the long-term effect as well. If adding on MST and she is not getting the proper results for the depression, then she can be added with the antidepressants as well.
Yeah.
But
Yeah,
giving the
definitely.
opportunity, giving the, because this is the first line management for in a combined symptoms. So I will like to say here that MST should be given a trial first.
So if the patient is having hot flashes or even not, but she just started her perimenopause state and previous she did not have any history of depression or mood changes, of course we can give her a try. I think we should agree on that. So now, as discussed, there are potential multiple and sometimes overlapping causes of sleep disturbances in midlife women as they approach and pass menopause. For some women, the sleep disturbances may be transient and without associated distress and therefore not require active treatment. However, others may experience severe sleep disturbances with a significant impact on functioning and quality of life. The challenge of making attribution of sleep disturbances to specific health conditions is made even more complicated by age-related increase in sleep that can be difficult to disentangle. So now we come the role of sleep diary. Does it help in a clinician in diagnosing different condition? What is the obstructive sleep apnea? And we'll be just restricting in this question to sleep diary. Does it help a clinician? Dr. Arif, I think I had given you this question. Dr. Arif?
Yes, you did, Dr. Maninder. And now patients come to us with varied complaints, and sometimes
varied complaints.
and sometimes it is very difficult to figure out different aspects of symptoms and to sort of strategize a plan as how to deal with them. So it is always a good idea to objectivize those things into proper channels so we can understand the problems better like physicians. So we can ask them to actually document what their symptoms are, what thing happens for how long, does it associate with any other symptoms, and how many hours do they actually sleep, what time do they get up in the morning. So in order to do that, how many times do they have to get up and go to the bathroom, if they breathe comfortably or not, and if that happens at any specific time of the night, do they cough or snore, or are they told by their partner that they cough or snore during the night? At times, do they feel too hot, too cold? They start off at too cold and then become too hot. Do they have bad dreams? Have they started to happen now, or have they always had them? Is there any specific pain? So whatever these symptoms are, it is sometimes a good idea to document them in an organized manner, so we can actually see emerging patterns. And then if we keep these diaries for a period of time, sometimes we can see the progression of symptoms as well, which makes dealing with them a little better. So it's a good idea. At times it is difficult, but then it also involves the patient into the care as well, which is again a very good idea, because if the patient understands what their problems are, they're able to deal with them better.
Yes. So sleep diaries can be a real helping to the general practitioners also and to the patients also to actually quantify and tell the symptoms and numerically also how many symptoms they are feeling, at what time they are getting and all that. So Jyoti, Jaiswal, now we have looked at into these cases now. So suppose if there is a patient of hot flashes, sleep disturbances with uterus and without uterus. So how you are going to treat her? Simple recapitulation of HRT menopause hormone therapy for our delegates.
Basically, if the patient is having uterus, then she will require, and having the sleep disturbances and hot flashes, MST is first line. If she is not having any other sleep disorder, then we will be giving the estrogen as well as progesterone. So 17 beta estradiol, nowadays it comes into the nowadays it comes in the tablet form as well. And without uterus, if she is having this kind of symptoms like post-hysterectomy seen, or in that situation, without progesterone, we can give. And even nowadays, we are having the combination of medications available with the name of femostone. So 1/5 and 1/10. So we can start with uterus that, and without uterus, we can go for the Premarin tablet or 17-beta estradiol, which is nowadays more recommended. We can go ahead with that. And madam, first case,
Tibolon.
Yes, even Tibolon can be helpful, madam. But the if MHT, if estrogen is not contraindicated, we shall start estrogen. Tibolon is also helpful for the reduction of the hot flashes and sleep disturbances. And it is the standalone drug, so there is no need for the progesterone supplementation, even if the uterus is there. So it is one way that thing is, and the quality of sexual life also improves with the help of Tibolon. And the first case you have discussed earlier, that the patient which are getting up again and again, she was not having urinary infection but having the genital tract atrophy kind of picture was there. So in that particular case, the local estrogen application, Premarin cream, will be helpful.
Yes, so that is there. Now, what question, Dr. Shahi?
Ma'am, I want to add something, ma'am.
Yeah, Dr. Shahi Farzana,
Yes,
supposing the patient is bilateral salpingo-oophorectomy with endometriosis. She's at 43 years old patient, and she now reports with ghabrahat, palpitation, hot and cold sweats, not able to sleep. So what are you going to prescribe to her? She was an endometriosis patient and had bilateral salpingo-oophorectomy.
thank you, ma'am. Already my previous speaker already told regarding the MHT. In this case, as the patient had THPLSO at earlier age, that is, she's only 43 years, and she has a palpitation, hot and cold sweats, that is vasomotor symptoms, sleep disturbances. So for MHT is the most appropriate answer for her. And in that case, as she is a case of endometriosis, so that we can give her an estrogen progesterone combination continuously, or we can give her estrogen and progesterone in high dose in the 12 days in a cycle. In that case, we can treat the patient. And if MHT is contraindicated, then we can go for other like gabapentin, clonidine, and SSRI, and so, and antidepressant.
So even in cancer survivors, we can give those drugs. We'll come to that later on. Now there is a new drug delivery system. Jyoti, can you talk about that? Lenzato.
Yeah, madam, we are very happy to know that even in India, the Themis is bringing Lenzato, the drug delivery system, which is a metered dose spray. It is not a patch. Earlier, we were having the dermal patches, but the weather of the India and in the whole SAFOM countries is not like that, which is very suitable for the patches. So this new drug delivery system, Lenzato, is coming in the meter dose. 1.53 is in a single puff dose, and it can be given on the inner aspect of the hand. But every time when a single puff given is a dose required, then it's all right, give at a one place. But if 2 meter doses are required, the patient is more symptomatic, then you have to give it at the 2 separate places for a proper absorption of that drug. And this drug is estradiol hemihydrate. So it has the benefit of just bypassing the liver metabolic effects on the liver. So the systemic side effects are really very less. Just few precautions are required here to be take care that before applying, you have to clean your hands, wash properly, dry it properly, and then apply it after shaking the, there is one delivery system which is very easily carryable wherever you want to have, and then you have to apply it once only. And the meter doses are in a particular number. So after the use of that, even if you think that some drug is inside there, then don't use that. It is coming nearly something, it is not very costly. It is coming something 1400, the whole device, and it is yeah. So but just you have to take care that after putting it, you should be cover it with this cloth, and the full sleeves cloth will be better, because if you will have a touch from any other place, so the absorption can be affected. And first 1 hour you should not have to
Okay.
have a hand washing, etc.
Yes, yes. Thank you, Jyoti, for that complete exhaustive explanation. But now, because we are running short of time, so with other modalities which are available with us are the Tibolon combination of Bazadoxine and CE, and it stopped going, working like this here. And then you have already talked about the local creams which can be given when there are local symptoms. And in India, available is Primarine Estrol cream, that is 0.3 to 2.5. Estrol is 0.5 milligram per day. Estrol Evelon tablets 1 to 2 milligram, and estradiol tablet 10-25 milligram. Then we have ospamifene, and we have other drugs also which we can make them comfortable, and perhaps their problems of sleep disturbances will be solved. Now their breast cancer survivor is one group where they have gained weight. She was binge eating at night time, migraine, BP, and diabetes. Now patient is cured of her hot flashes. Thank you to all the 3 gynecologists. She's not having nocturia and sexuality problems, but her sleep problems are persisting. Now the patient has come now after 3 months, and she is having thanking us for not having those symptoms, but she's still having daytime fatigue, feels drowsy, goes to sleep in the often, difficulty in driving also. She has gained weight. Her husband informed. Luckily, husband came along with her, and he informed that she snores at night. Sometimes she chokes up and stops breathing. He's worried. So what to do with her? Same case like can come Lisa, 51 years old, executive, reports to office with history of getting up in the night as she's not able to breathe. She feels she's being suffocated, and LMP was 2 years back. Her BMI is 30, overweight. She's diabetic, complains of daytime sleep, had history of PCOS, gestational hypertension, and now she is normotensive at this time. So you know the previous and past histories, how important they are. We cannot ignore these histories when we look after the cases, but because of paucity of time, I could not take them. Now, Dr. Yogesh Newpend, who is not only an ENT specialist, but a sleep therapist also, and he has been introduced rightly about that. Does weight gain cause sleep apnea? How do you diagnose? By polysomnography or other investigations? What is actigraphy and what is the management? These are, so obstructive sleep apnea approach and management to you, Dr. Yogesh.
Thank you, ma'am. Thank you, ma'am, for giving this opportunity, and thanking the SAFOM team. Actually, the obstructive sleep apnea, we all know it is upper airway obstruction due to some anatomical or non-anatomical factors. And when the upper airway obstruction lasts for 10 seconds, we call it a sleep apnea. But it begins with the snoring. If we see somebody snoring today, we can understand that guy is going to be a sleep apneic tomorrow. Because
that's why that woman was snoring. Yeah.
Yeah, it is a beginner as a snorer. So once the snoring starts, so gradually there is a tissue damage, because every day if the person is vibrating in his pharynx or hypopharynx area, there will be a lot of neuromuscular damage out there. So progressively that person today who is snoring, if not managed today, is going to be a sleep apneic tomorrow, that is after a few years. So the progressive damage to the soft tissue will lead to the sleep apnea. And we all know if there is cessation of breathing lasting for more than 10 seconds, that is apnea. And if there is effort to overcome that, that is obstructive sleep apnea. So clinical evaluation begins with a lot of history taking and a lot of clinical examinations and a lot of office endoscopy and in lab study. And finally, we do a drug-induced sleep endoscopy. With the sleep, as correctly mentioned by previous speakers, we have a lot of questionnaires, stop banks, Berlin question answer, Apathy scales are there. But after that, when we find the patient is having some symptoms that mimics the sleep apnea, then we ask the patient to undergo a sleep study to know whether the patient is a snorer or sleep apneic. So we can do 2 types of sleep study, that is home-based sleep study and a hospital-based study. But nowadays, which are much more in favor of the home study, because in home study, the patient has his own bed. So chances of getting the greater yield of the report, or the day-to-day sleep report comes with the home sleep study. And this sleep study will give a lot of data about whether the patient is simple snorers or sleep apneic, and the patient is having central mix or the severity of the sleep apnea. So after the sleep study is done, then we do an office endoscopy to see whether there is an anatomical factor which is causing it airway obstruction leading to the sleep apnea. So after the office endoscopy is done, then we give the treatment modalities to the patient. But like before, one size fit all doesn't exist. So no more only a CPAP or a sleep apnea nowadays. We have to give a bunch of the options to the patient. So we start there are various options to the patient that we give. We start with the weight. Another slide, ma'am. So we start with the because the treatment of this individual patient are so different, so we give a bunch of treatment options to the patient, like weight reduction, positional therapy, mandibular advancement device, tongue retaining device, PAP therapy, and nowadays the hypoglossal nerve stimulator is emerging like anything. And if the patient doesn't want anything, then we give them a surgery. So weight reduction helps a lot. So we at least advise the patient to go for 25% of the weight reduction. Then the positional therapy is equally effective in patient. So we normally ask the patient to lie on their lateral side, so not to sleep in supine position, but in a non-supine position. So in either position. In Amazon, we can get a lot of the sleeping pillows or sleeping quilts or sleeping belts out there, which help to sleep in the lateral position. Then we ask the patient to do some sleep apnea exercise, which are available in YouTube. So we have also uploaded the various type of the sleep apnea exercises in YouTube for our patient local language. So these are the exercises which helps to increase the tone of the muscles of the tongue, of the palates, of soft palate and hard palate, so that they have less chances to get collapse at night. So there are a lot of sleep apnea exercises in the YouTube that can be followed. Then after that, we ask the patient, so according to the severity of the patient, we can go for an oral appliance also. There are a lot of oral appliances. The mandibular advancement device are there, and tongue retaining devices are also available in the market. The basic principle of this mandibular advancement device and tongue retaining device is just to take the tongue out of the airway. So here we can see in this video, some obstruction is there at the level of the soft palate and a tongue. So when this mandibular advancement device is applied, it pulls the lower jaw forward so that automatically tongue comes forward, so which comes out of its airway. So the patient who is having the problem with the obstruction get relief from this obstruction, especially at night. So same principle applies for the tongue retaining device. This tongue retaining device pulls the tongue out of the airway and opens up this airway. Like we can see in this below 2 figure, this tongue retaining device pulls the tongue out forward. In doing so, it opens up the airway so that the patient with sleep apnea get helps. But ideally, the best treatment modality is a CPAP. So we all know the CPAP is a simple pneumatic splint, which normally splint the airway when with the ear. So it is a simple room air which is given through a mask, which splints the collapsed airway, and the patient airway is open. But though it is a best modality of the treatment still existing, but we know the compliance of the CPAP is very, very, very less. Less than 30% of the people, they use a CPAP for longer than 5 years. A lot of the study has shown that. So we give an option to the patient that, okay, if you don't want to have a CPAP, then we can give you a surgery. So we can do a lot of surgery like soft tissue surgery, skeletal surgery. And the recent advances is a hypoglossal nerve stimulation. So this is quite costly modality of the treatment. So in the indicated patient, this hypoglossal nerve stimulator is implanted in the chest, and the stimulator is kept in one of the branches of the hypoglossal nerve. So if there is any collapse in the airway, the nerves get stimulated and tongues is protruded outside of the airway, which opens the airway. Though the treatment modality is costly, but it is much more effective modalities of the treatment in selected cases. And in surgery cases, the gold standard surgery is a maxillary and mandibular advancement, which is we do as a and call as MMA. So in the next slide, we can see the skeletal surgery or the bony surgery is being done, which is a most effective way of treating the patient. It is a MMA, that is a maxillomandibular advancement, in which we make a cut in the maxilla and mandible and pull it forward so that the airway opens up. So it is a most effective way of treating the patient. And the AI in sleep apnea. So because we do a lot of polysomnography, there are a lot of data coming out from the polysomnography, and a lot of the data that is coming from our office endoscopy, which help us to give a lot of understanding. And when the AI uses all this data, we have got a better understanding in the OSA phenotypes, and we can also give some which patient will be get benefited from CPAP, from surgery, from mandibular advancement device. And a lot of the researches are going in Stanford. So they have developed an ultra AI based ultrasound. We can scan the airway and tell that this patient is having obstruction in this part of the airway. And other is that electronic tracheal trans. So electronic the tracheal sound detector can be placed in the trachea, which can also help to identify the level of the obstruction in the patient with sleep apnea. So a lot of AI things is going in the world.
So lots of work is being done in sleep apnea and lots of surgeries. We are really enlightened by your talk, Dr. Yogesh, because I think some of the devices can be taken by most of the gynecologists may not be suffering from sleep apnea, but they don't know. They don't know because they just get up in the night and they don't know that this was because of the obstruction in their air pathways, and that leads on to their effect on the cardiovascular system, which is very, and sometimes the sudden deaths can also occur in sleep apnea.
True, ma'am. It is, yeah.
Yeah, so actigraphy are the wristwatches which can be worn at night time and can tell you about sleep cycle and all that, but they are not effective. But we have now, instead of these polysomnography big machines, we have some small which can be attached to your nails also, and they can also be taken for home sonography study also.
It is one of the modality of the home sleep investigation.
Home sleep investigations now. So complication we have already taken now. Now we come to Dr. Neha Kapoor about talking about other sleep disorders, because we have talked about estrogens, we have talked about progesterone and other hormones, and we have talked about obstructive sleep apnea, mood disorder, depressions, everything. So Dr. Neha Kapoor, now to you about other sleep disorders which are found in aging population. Sometimes they might be because of some hormonal effect or may not be because of the hormonal effect.
So talking about gastroesophageal reflux disease and its relationship after menopause. So it is seen that after menopause, because of a lower tone in the esophageal sphincter, and also there is a reduced gastrointestinal motility, and because of which the food will move slowly in your intestinal tract, that can all lead to the gastrointestinal symptoms like bloating and dyspepsia and gastroesophageal reflux diseases. And that, of course, can contribute into insomnia. And there are a lot of patients who will come symptomatic with GERD, and they have a lot of, especially these symptoms happening in the night, because when you're lying in a supine position, you can have, and you've had a heavy meal and a heavy dinner, you can have these kind of reflux more at night. So treatment with proton pump inhibitors, which like pantoprazole or esomeprazole, they help in reducing the pH of the stomach and reducing these GRD-like symptoms. And of course, when these GRD-like symptoms are happening in the night, they are contributing to insomnia. So to treat them with proton pump inhibitors would be a good idea to reduce the reflux disease and also help in the treatment of insomnia at night. Because if the patient is having these symptoms at night, it is going to interfere with sleep, and that is going to lead to insomnia and daytime fatigue. Of course, if we talk about now, okay, coming on to restless leg syndrome. So restless leg syndrome is quite a common neurological symptom and a disease that we commonly see in the OPD. And it has also been associated with sleep disorders. because what commonly the patient complains is that he has this uncomfortable sensation in the legs when the patient goes off to sleep, which can happen at night or even at day when they're going off to the bed just to catch a nap in the daytime. So they have an uncomfortable sensation in the legs and they have an urge to move their legs. And when they do move their legs in bed or when they get up out of their bed to just take a walk, these symptoms, they get relieved. And the pathophysiology of this RLS or the restless leg syndrome is basically at the level of dopamine, that there is reduced dopaminergic neurotransmission at the level of brain and down to the spinal cord, and also glutamate transmission that is involved in the pathogenesis of RLS. And so what happens is that these symptoms, when they occur when the patient is going off to sleep in the night, they lead to interference in sleep. And RLS will then lead to insomnia, because when the patient is going off to sleep, he will have these uncomfortable sensation in the legs, and that will interfere with sleep and that will lead to insomnia. And then when the patient gets up in the morning, he does not have a restful night sleep and he is not well rested in the morning, and he will have daytime fatigue and daytime sleepiness as well. And when we talk about RLS in menopause or postmenopausal women, it has been seen that it again leads to insomnia, and what the pathogenesis is related is to estrogen as the hormone. It has also been seen that in pregnant women that RLS is again becomes a symptom. So why this paradoxical phenomena is happening in menopause as well? So what has actually been seen in studies is that it is actually the fluctuation and the fall and the rise in the levels of estrogen that is leading to the initiation of this pathogenesis at the level of the dopamine and the glutamate transmission at the level of the brain and the spinal cord, that is leading to the RLS-like symptoms. And when we talk about periodic leg movements of sleep or the periodic leg movement disease, that again leads to insomnia and these kind of movements. So when periodic leg movement occurs, it is somewhat similar to RLS, but in periodic leg movements, there is sudden jerking-like movements, which is involuntary movements that occur during sleep, which are not in control of the patient. And they again interfere with sleep, and they again lead to insomnia, and they again lead to fatigue and daytime sleepiness and grogginess. And again, they have been associated with the similar pathogenesis as the restless leg syndrome. When we come to the treatment part of RLS and periodic leg movement, movement of sleep disorders, it is basically replacing dopamine as the hormone in form of pramipexole or levodopa sometimes. If it is associated with iron deficiency, because iron deficiency is also associated with RLS, iron replacement in form of IV or oral treatment has also been associated to improve these RLS or PLMS like diseases that lead to insomnia. Otherwise, gabapentin or pregabalin can also help in improvement of both RLS and PLMS, both these symptoms leading to insomnia. And if in case you have RLS associated with iron deficiency, or you are having hot flushes, and of course menopause being there in picture, and of course estrogen and hormone therapy can also help in reducing these symptoms.
Thank you. I think, Dr. Neha, you have very rightly explained and enlightened that when these patients come, when we are investigating them, we should do their hemoglobin. That is very important. Thyroid, we should also be doing along with the other investigation. Perhaps in these patients, we have to do KFT and LFT and all these patients, because these are the special group of patients where they can have multitude of problems also, and they might be taking lots of drugs also, and drug interactions have also to be looked into.
Yes.
Now we come to very important group, breast cancer survivors and sleep disorders. Now approximately 20 to 70% of women with breast cancer suffer from insomnia, including complaints of difficulty staying asleep, difficulty falling back to sleep, and sleeping less overall. Now, patient was treated by Jyoti, Jaiswal and Dr. Sohail Farzana, but despite improvement in hot flushes, now we are continuing those cases where they had given treatment for hot flushes and sleep disorders, but they improved with the hot flushes, but awakening and nightmares and early morning awakening continued. So now what can be done in these cases where we have given them hot flushes treatment already with menopause hormone therapy?
What happens is the vasomotor symptoms where we're having hot flushes and where we know that now the patients are having nightmares, and so basically nightmares and dreaming is more associated in REM sleep part of the stages of the sleep when we talk about it. And what has been seen that benzodiazepines, or for that matter, SSRIs, the selective serotonin reuptake inhibitors, or even serotonin and the norepinephrine reuptake inhibitors, or these kind of medicines can help you sleep better. That can help you with your anxiety as well. It can also help you with your depression, and that can help you combat the insomnia and also reduce the frequency of dreaming or the nightmares that are occurring in a particular patient, and help you improve your sleep quality. So SSRIs like escitalopram or fluoxetine or citalopram, so these are the common SSRIs that are prescribed. And if we talk about SNRIs, so we have venlafaxine, desvenlafaxine, and duloxetine. Duloxetine is very commonly even prescribed for chronic pain syndromes that occur in elderly age groups, in postmenopausal women as well, where you have fibromyalgia is also occurring, and they act as very good antidepressant also. So one can use a combination, or you can use an SSRI, SNRIs, or you can also take help of benzodiazepines where you want to have a sleep onset, help you sleep onset insomnias, to help you get down to sleep, to get down to bed so that you can have a good time sleep in the night. So that'll help you have a good quality of sleep. You get up fresh in the morning so that you have a good daytime working period of the day, and you're not having daytime sleepiness, and you're not feeling difficulty in concentrating on your daytime work. Along with that, if we talk about cognitive behavioral therapy, it's very important to understand that sometimes non-pharmacological treatment can work wonders. So when we talk about cognitive behavioral therapy, it's important to practice sleep hygiene. Sleep hygiene includes going to bed at fixed time, getting up in the morning at fixed time, understanding that the going to sleep is kind of a ritualistic task. You have to understand that the bed is to be used only for sleeping and not for watching television for a very long time at the night, or doing your work on the laptop sitting on the bed. You have to avoid taking coffees and other stimulants late in the evenings after 5 o'clock or 6 o'clock or 7 o'clock.
Hygiene will be, Neha, Dr. Dasanti will be taking.
Okay.
So I think you have very elaborately explained role of SSRIs, SNRIs, cognitive behavioral therapy, benzodiazepine, sedative hypnotics, which can be given for the early onset to sleep. That is very important. And what is the important thing was that in breast cancer survivors, we cannot give the fluoxetine who are already on tamoxifen, because they inhibit the enzymes which are responsible. So we have to take care about those drugs only. Otherwise, all these drugs, they can be given easily to these patients. Now we have covered all hormonal, non-hormonal. Yes, there was one thing mentioned about we can take, because we are shortage of time, of the drugs like cohosh, black cohosh, and other drugs which are on-counter drugs can also be tried for sometimes in these cases. Now, Dr. Dasanti, will you go please quickly with sleep hygiene? I have written wrongly, sorry.
As she said, both bedroom environment and daily routines promote consistent, uninterrupted sleep. So you have to optimize the sleep schedule, pre-bed routine and daily routines, and have a fixed wake up and sleep time to have a good sleep. So actually it should be necessary to avoid caffeine consumption, mainly coffee, soft drinks, and even chocolates in the late afternoon, probably just before 6 p.m. it should be finished. You should not take those things after 6 p.m. If you want to drink something, malted milk will do. It will be helpful to have a good sleep also. And exposure yourself to bright light during the daytime. It will actually important to help to improve the biological clock to reset itself each day. So make sure that your bedroom is comfortable for sleep. It should be dark, quiet, and uncomfortable, without and it should be cool as well, because of the hot flushes and other things. Patient won't be able to tolerate heat, so it should be cool place, and sleep on a comfortable chair, pillow, and even the mattress is important. So don't go to bed feeling hungry, and even a full diet also should not be done. It should be moderate diet, and develop a relaxing sleep routine should be done, because if some are used to bathe before sleep, it should be continued as such. And if they want to listen to music before sleep, it can be continued regularly rather than ad hoc manner. And even if they want to do some reading before bedtime, it should be continued regularly rather than doing on and off. So then it should be actually your bedroom should be kept for only for sleep as well as for sexual activities only. And reading, using cell phones, computers, even video games, even all the other textbooks, all these things should not be kept on the bed, and it should be only for sleep. So that bedroom should be suitable for the sleep environment only. So exercise is the other important thing. It should be done at least 30 minutes per day, at least 5 days out of 6-7 days, at least 5 days should be done. It should be 30 minutes per day. Regular exercise will help to have a good sleep. And it should be avoided to have pets in the room. If you get pets in the bedroom, it also will be a problem for sleep, because they wake several times and it will affect your daytime routine. So don't start arguments or discussions in the bed. Actually, you have to finish all these things before going to bed. And if you wake up in the middle of the night, you have to sit for a while rather than just lying in the bed thinking and waiting the sleep to come. They should sit on a chair and start reading a boring book or paper, or start studying, then you feel sleepy. So after that only you have to go back to bed. So it should be like that, and it will help you to have a good sleep pattern, and it will help you to have a good sleep pattern throughout the life. So that's what I feel as a good sleep hygiene. Probably it will be helpful to have a nice sleep pattern.
Thank you.
Yeah.
I think Dr. Yogesh has already highlighted on artificial intelligence, so we'll leave it because there are many gadgets available which can be worn on the wrist, and they can tell you about your sleep time and when did you get up in the night, and then you can take a proper help from the sleep therapist if you are having a problem. Gadgets should not be used, like you have already said. So now we come to the main question which I asked you: keep sleeping. What about the nightmares and the dreams? Dr. Neha has touched on that subject already. So can you quickly go through why do we get dreams?
Shall I do that, or Dr. Neha?
Yeah, so just shortly. Yeah. Can you summarize it? Why do we get the dreams and nightmares?
Yeah. This Dr. I think it's my problemized slide. Yeah. So actually dreams, why do we get dreams? Actually, no proven evidence or any theory on why we dream. So there are different theories about the purpose of dreaming. Actually, there are, one is built-in memory. Dreaming has been associated with consolidation of memory, which suggests that dreaming may serve an important cognitive function of strengthening memory and information recall. So other theories, processing emotions, the ability to engage with and rehearse feelings in different imagined context may be part of the brain's method for managing emotions. Then other thing, expressing deepest desires. So actually other theories, the mental housekeeping, periods of dreaming could be the brain's way of straightening up, clearing away partial, erroneous or unnecessary information. The other thing is instant replay. Dream content may be a form of distorted instant replay in which recent events are reviewed and analyzed. So incidental brain activity, this view holds that dreaming is just a byproduct of sleep that has no essential purpose or meaning. So many experts believe that we dream due to a combination of these reasons rather than any one particular theory. Many researchers believe that dreaming is essential to mental, emotional, and physical well-being. Some scientists suggest that dreams serve no real purpose at all.
So nightmares are again seen more in the second half of the night, and again they're again in the parts of the dreaming where we're seeing it more in the REM sleep. What has been seen is that when you are having a lot of stress, fatigue, and if your sleep time is not proper, or when you are having a lot of anxiety, depression, or some kind of a trauma, post-traumatic stress disorder is associated with a lot of nightmares. Again, some drugs like alcohol intoxication and certain, it has also been seen that certain antidepressant also sometimes can lead to certain nightmares or some these kind of night terrors or parasomnias have been associated with these kind of REM sleep behavior disorders or nightmares for that matter. So over to you, ma'am.
So what are you going to advise for nightmares?
Ma'am, again, so for nightmares, a lot of cognitive behavior therapy will have a play, trying to reduce the anxiety. Anxiolytics can have a somewhat help trying to reduce any stress, if there's any post-traumatic, and the triggers that are leading to the reason for nightmares. And to an extent, maybe anxiolytics and SSRIs can help to an extent to reduce the nightmares and to improve the quality of sleep and the triggering factor that is reduced, that is causing the sleep disturbance and leading to the, basically trying to understand every patient will be need be a different individualized reason for why he's having or she is having such problem.
Yeah, so complete history and cognitive behavioral therapy is the mainstay in these cases, along with some changes in the
pharmacological treatment.
So now we come to the conclusion of this wonderful study by wonderful panelists and the experts which we have concluded. We know that clinicians should be aware of prevalence of sleep disturbances and sleep disorders in this population and refer women for evaluation if a sleep disorder is suspected, particularly in the light of morbidity and mortality associated with sleep apnea. So should be referred to diagnosis, should be treated because substantial improvement in quality of life and health related outcomes can occur. So these, whatever we have seen earlier, what are the causes of sleep, hormonal to lifestyle, depression, insomnia, restless leg syndromes. We have to look into diagnosis by polysomnography or by objective questioning, clinical examination, or making them write the objective questions where they can answer what problems they are having. The treatment can be, if it is associated with menopausal symptoms, maybe 11 symptoms of them. And if they need treatment, then they should be given menopause hormone therapy. We have various therapies we have discussed in different discussions. If the patients are the cancer survivors, then or they cannot be given menopause hormone therapy. In those cases, we have to give SSRI, SNRIs, gabapentin, even hypnotics can be given, benzodiazepine can be given in those cases. But fluoxetine and these agents cannot be given in breast cancer survivors because they interfere with the enzymes, the tamoxifen, when they are on treatment. That there. Cognitive behavioral therapy, especially internet-based cognitive behavioral therapy, is also being considered as a big boon for these patients. And non-hormonal and other therapies like yoga, some exercise, not heavy exercise before bedtime, and using the bed for the bed sleeping and for the sex only is really going to help the patients a lot. And then there is a legend which says when you cannot sleep at night, it is because you are awake in someone's dream. So I request all of you that if you have stopped dreaming about me, and that would be great, I would have a good night's sleep. Thank you very much to all those who have participated in this wonderful, wonderful webinar, which was need of the hour.
In Bangladesh, we are using a hormone that is drospirenone plus ethinyl estradiol combination.
That is ethinyl estradiol and gestatin.
Drospirenone.
Drospirenone, yeah, perimenopausal age group, you can give that. because it's a metabolic friendly hormone. So that can be used. So different countries now, they have different hormonal preparation. Next time, everybody should bring the hormones which are available in their countries. So let's see and compare what our women are getting in menopause hormone therapy. Yeah, Dr. Yogesh, thank you very much, because he has somewhere or other to go, for being here and for giving us a very, very productive inputs into the sleep apnea, because we didn't know those details of how to do the polysomnography, how it helped, and especially the surgeries and the gadgets which are available. Thank you very much. Thank you to all the panelists, Dr. Arif, Dr. Jyoti, Dr. Shahi, Farzana, and Dr. Shreyashi, and Dr. Yogesh, and Dr. Dasanti from Sri Lanka, who gave so much inputs, and Dr. Neha Kapoor from India. She's from Faridabad, our own Hospital of Asian Institute of Medical Sciences, and she's a great neuro plus sleep therapist also. So everybody's inputs have been really, really excellent. And I think next webinar series is by Sri Lanka, that is on 18th. And that will be on the mood, irritation, anxiety, I think. That is what they have been taking, and we will like to have the volunteers from all the countries. And I'm again thankful to Dr. Jaideep Malhotra, Dr. Rubina, Dr. Rohana for being here, and especially to all the council members of the South Asian Federation of Menopause Societies, who are standing in solidarity and helping us run these webinars, because I think this is my need key. We should be able to reach out to the masses with the right message, so that they know what their menopausal symptoms are there. But even all the private practitioners, they should know that these symptoms which the woman is presenting is because of the hypoestrogenic state, so that we can recompensate her whenever required. When not required, we can give them alternative therapies, but when required, estrogens are the best treatment available. And the progesterone can be in the form of dihydrogesterone or micronized progesterones, which both are available with the Jagsonpal group. And thanks to our Jagsonpal Nari group for giving me continuous support, which cannot be described by the words only, because she's there whenever I need, for doing so many spelling corrections also every time, because when we are doing from the multinational, it's very great spelling. Now we have to give the certificates to all the faculty now. Who will do the honors? Dr. Dasanti, you can do the honor, or Dr. Arif can do the honors.
Pleasure, ma'am. Thank you very much. The first one is mine, so thank you very much.
Yes, this
first
is
the Professor Arif. I'll do his honors first. This is the SAFOMS webinar series, Midlife Quality of Life Issues and Menopause Rating Scale. Certificate of Acknowledgement and Appreciation awarded to Professor Arif Tajammul, Professor of Obstetrics and Gynecology, Allama Iqbal Medical College, Lahore, Pakistan, for participating as faculty in webinars, Sleep Disorders in Midlife Quality multidisciplinary team on Thursday, 13th April 2023. We are really thankful and honored by your presence, and the way you have described the things have, of course, made the things easier for all the gynecologists who were attending as a delegate also. Next.
Thank you very much, ma'am. Honored.
Now, next you do the honors, sir.
And thank you so much, Professor Jyoti Jaiswal, Professor and Head of the Department of Obstetrics and Gynecology at PMMM Medical College, Raipur, India. Thank you so much, madam, for participating into this great seminar, and it was a pleasure to have you.
Thank you so much, sir, for the honor.
And Professor Shahi Farzana Tasmin, former Professor of Obstetrics and Gynecology, Rangpur Medical College, Rangpur, Bangladesh. Thank you so much, madam, for joining and giving your valuable thought to this webinar.
For your appreciation, thank you very much, sir.
And the next certificate goes to Dr. Neha Kapoor, Senior Consultant and Head of the Department of Neurology, Asian Institute of Medical Sciences, Faridabad, India. Thank you very much, madam, for your insight and input into this webinar. Thank you.
Thank you, sir. Thank you so much.
Where are you? You had to do the honor.
And the next certificate goes to Dr. Yogesh Nupene, Associate Professor, ENT and Hand and Neck Surgery, Tribhuvan University Teaching Hospital, IOM, Kathmandu, Nepal. Thank you so much, Dr. Yogesh, for your input and into the new technology and things that you've introduced into this webinar today. So thank you very much. And the next certificate goes to Dr. Liananga Dasanti Deshanti Akimano. Dr. Maninder, I think you did a better job at pronouncing her name. So, madam, many apologies if I've misspelled your name. Consultant psychiatrist, Colombo
She has
South
actually
Teaching
written
Hospital.
her complete name. Yeah.
Hospital, Colombo Villa, Sri Lanka. Thank you very much, madam, for your participation and into your insight.
Thank you very much.
Dr.
Thank you very much for your honors, sir. Thank you.
And the last one is Dr. Chanda Srivastava. She has just sent her message that she is not able to unmute herself. I don't know. She has logged out and again logged in, but still she's not able to do it. And she said, can you sum up from my side? So Dr. Chanda Srivastava, SAFOMS Webinar Series Midlife Quality of Life Issues and Menopause Rating Scale. Certificate of Acknowledgement Appreciation awarded to Dr. Chanda Srivastava, Consultant Obstetric Gynae, Nepal, and she is the President of the Nepal Menopause Society, for participation as faculty in webinar Sleep Disorders in Midlife Quality of Life MDT on Thursday, 13th April 2023. Thank you to again Jagsonpal and all the panelists. Comments are invited.
Thank you, madam.
Any suggestions or comments for future?
Ma'am, the last certificate which is coming to you, Professor Maninder Ahuja.
Okay.
Director Ahuja Healthcare Dental and Infertility Center at Faridabad, India, for not only participating as faculty, but also being the convener of this webinar series, which will go on till December. So every month till December, we'll be having good insights.
Yeah, mostly on the second Thursdays from 7 to 9 p.m. Let's have a picture. Smile.
Okay.
Yes. Again, smile. Nice pictures. Thank you, everybody. Thank you, Neha, Dr. Arif, Dr. Shahi, Farzana, Dr. Dasanti, Akimi, Mana. That is easier. Doctor, that is okay, huh?
Yeah. Okay, okay.
Yeah, Jyoti,
Thank you, ma'am.
Jaiswal, and myself and Dr. Deepika Chabra and
Thank
Dr.
you
Neha
so much,
Kapoor,
ma'am.
Dr. Yeah, everybody was here and everybody's inputs were really great. And
Thank
let's wait for the next. And even if you are not faculties, please come and join and update us and raise our morale also, because working into the midlife women for their midlife health is still very challenging and it is an uphill task so far. Thank you very much.
Thank you, ma'am. Signing off.
Thank you from Jagsonpal as well. And for the menopausal women, we have a few solutions, like we have LycoRed Cell Protector, the ultimate cell protector for managing the oxidative stress. This LycoRed contains lycopene as the lycomato complex plus zinc and selenium. And we have over 35 clinical trials with 56 publications out of it with this same LycoRed. We also have LycoRed syrup for day-to-day stress, which manifests as oxidative stress. Enhance the day-to-day immunity with LycoRed syrup, which is enriched with micronutrients, micro and macronutrients, and it is sugar-free, so can be given to the diabetics as well. Improve the immunity and metabolic fatigue with LycoRed syrup. For the women, for osteoporosis and for improving the physical functionality and improving quality of life, we have nandrolone decanoate injections of 25, 50, and 100 mg as injection Metadec. And Doxypal DRL, doxycycline with lactic acid bacillus, the antibiotic with least reported resistance. So looking forward to support from all of you, and thank you so much. And our next webinar coming up is on this Monday, 17th, where we have PPH being discussed by the postgraduates of Kasturba Hospital. This is a PG class from Delhi Association of Obs and Gynae. Of course, this is our schedule, which will be with SAFOMS every
now
month.
18th April. And then, no, this is done 18th May now. Next one is 18th May, mood, anxiety, and irritability. 13th July is physical and mental exhaustion. 17th is sexual problems. And then 14th is bladder problems. I have not given them proper names so far. And dryness of vagina and burning in the vagina, because that's a big issue. We have to discuss many angles, which we are not discussing. And joint and muscular problems and risk assessment tools on the 14th December. After that, we can start prescription writing exercises if we get the time in the next year. Till then, bye.
Okay,
Thank
bye.
you. Bye-bye.
Bye.
Good. Good night.